account. Dom is a senior biomedical scientist at the University Hospital of Wales, and is also the training coordinator, excuse me, and works with placement students on their research project. HORIBA installed the first L-shaped track into UHW, into the main hospital in Cardiff, and in addition to that, we installed 2 additional analyzers into the sister site at Landock, and since then we've installed a further 2 analyzers, one in the Velindre Cancer Centre and the other one in the day unit in UHW. So they've got the full system in Cardiff and use it very proactively. So I'll hand you over to Dom. Thank you very much.
Hi. Thank you very much for that, Andy. Very kind of you. I'm here today. I'm going to talk about a study that we've done between the 2 methodologies of counting platelets on the Yumizen platforms. So hopefully I have a little bit of control over the screen. We'll have a look. There we go. Okay, so I'm going to just briefly go through some basic platelet theory, some information about the setup for what we did, the actual results of what we've done, and then comment briefly on some outliers and then take questions. So hopefully, there we go. So first things to do is set up what we're actually talking about here. So what are platelets? So most people here are going to listen know that platelets are fragments of megakaryocyte cytoplasm. They are a versatile component that is used in hemostatic response to injury. They form a platelet plug to stop bleeding, and they act as immune modulators in inflammation and infection. They also play a role in tumor immune evasion, and they shield some tumor cells from recognition by cytotoxic lymphocytes. So they have a very important role to play actually within our hemostatic response and within our blood picture as a whole. The platelet count is usually used by clinicians, by those dealing with patients, to assess the risk of bleeding or the chance of a risk factor for thrombosis, and to diagnose and monitor complications alongside platelet disorders and conditions. So a couple of common conditions then, we have thrombocytosis, high platelet counts, any count above 450 times 10 to the 9 per litre, can be indicative of myeloproliferative diseases, polycythemia, myelofibrosis, essential thrombocythemia. They can also be found raised in chronic inflammation, acute inflammation, infection, and solid tumor cancers. Post-surgery, you can get a raise in your platelet counts as well as a drop as a reflective response. So that's thrombocytosis. Thrombocytopenia then, low counts, usually considered to be indicative of bone marrow based disorders if chronic, but also seen in things like aplastic anemias, again back to the leukemias, carcinomas, cytotoxic drugs, liver and splenic damage, and idiopathic conditions, and heparin-induced thrombocytopenias. They can also be found reduced in disseminated intravascular coagulation. So some reasons why we're important. Platelets give rise to a lot of diagnosis for a lot of different disorders. Next slide. There we go. So what methodologies do we actually have for counting? So for accurate platelet counting, the historical methodology has been impedance counting. Impedance count is basically a measure of the resistance as an object passes through the aperture where a current is applied, and that resistance change is measured, giving you a estimation of the size of the object passing through, as the resistance is proportional to the charge carried by the object. So that's the common way that it's done. It's widespread. What it can't do is it can't differentiate the larger platelets from the smaller red cells, or the tiny platelets from red cell fragments. So it's good up to a point, and it's at these gray areas that we need to have an alternative methodology of looking at things. that alternative methodology could be optical scatter. Optical scatter is the ability of automated analyzers to discriminate platelets from non-platelets via the use of a light beam being transmitted and the light absorbed or scattered being measured. The original technology introduced by HORIBA is regarding platelet extinction. There's some very interesting papers out there that I would strongly recommend anybody interested go and read, but it is based on polychromatic absorbance comparison between platelets and microcytic red blood cells. The third methodology then for counting platelets is the international reference method, recommended by the International Council for Standardization in Hematology, which is optical fluorescence or immunological platelet counting. It is a very complicated methodology for day-to-day use. It needs expertise on the part of the actual scientist performing the assay, and it does give rise to very accurate results regarding platelets. It's looking for specific CD41 or 61 markers on the platelet cell surface. So, too many slides. So, what statistics did we use to look at our actual comparisons? So, it was a very simple methodology we were looking at. We had two options on the same analyzer for counting methodologies, impedance and optical. So there's no variation between analyzers to take into account. There's no variation between transit patients or samples. So we could use some very simple comparisons. We chose to use the passing Bablock regression, or R-squared regression, which just looks at the two methodologies and plots X versus Y, and then compares the slope to determine how close to a perfect correlation of X to Y it is. And that's reported as an R-squared value. The other methodology that we used was a Bland-Altman plot, and that is a methodology for comparing two measurement techniques. And what it does is it looks at the limits of agreement present between the populations. It's a way of determining whether there is any bias within the results you are looking at. So passing Bablock looks at how the two results respond to each other, and Bland-Altman looks at whether one result is significantly different to the other. So moving on, before we could start doing any of the comparisons, we needed to do a brief precision test. And to do that, all we did was run 15 samples at different ranges, low, normal, and high, 5 samples at each level, multiple times, and get an idea as to what the CV was for each parameter. So at the low level, samples running below 150, we had a coefficient of variation of 10%, which seems quite high, but actually it's at worst it's 15, at best it could be as small as 3. So actually the variation at the low end was very good. And then as we climbed up the levels between 150 and 450, we found it was between 5 and 6%. And then at the very high end, where values could go up to 1,000, we were looking at a variation of between 3 and 4%. So actually the precision for the analyzer in both methodologies was really good, very good for the values we were running. So let's get into the actual details of the values. So first off, we're going to look at the low count values. We ran 93 samples by this methodology, and hopefully I can show you with a laser pointer. There we go. So you can see here the correlation between the two sets in the passing Bablock was really good, really tight, within the acceptable ranges. The majority of samples ran correlated between both methodologies. we were very impressed at the tightness of the run between the two values. There were a few outliers, and I'll come back to discuss those at the end, because these are patients of interesting clinical significance, and the disease states in them could be supported through diagnosis via this methodology. So, and those same outliers showed up as well on the Bland-Altman plot. So you'll see that where we have outliers on the passing Bablock, you can see them show up again on the Bland-Altman. So for the low level, there was very, very little bias between the methodologies. It was pretty much run for run accurate between both values, with a bias of as low as -1.7 is next to nothing for a Bland-Altman plot. So we were very impressed at that at the low end. For the normal counts, that's counts running from 150 to 450. We ran 53 samples, and we found much fewer outliers. The few that we did run were running just above our confidence limits for the actual R squared, but the R squared itself came out much tighter again. So it just proves that for normal values, there's no effective difference between the optical and the impedance methodology. The Bland-Altman plot showed that there was a bias. We need to do a bit of further study and determine whether that was bias due to the methodology, or whether it was just bias due to the sample selected, that there was a delay in getting them processed, so therefore the platelet count changed. What we probably need to do is perform multiple precision runs on each sample to get a better idea as to what the actual individual per sample bias is, especially for the normal range, but that's further study down the way. As it is at this point, we're still showing bias, but it is well within the confidence interval for what we were looking at, 95% or K equals 1.96. So we were very impressed at that for the normal range. And then the final set that we ran through, hopefully if that works, there we go, was the high end set of counts greater than 450. In this case, we had counts ranging from 450 all the way up to 1200 at one point for one of the counts. So we got a good range at the very top end. And again, you can see the R squared, very good, greater than 0.9. So a very good correlation there. Again, a couple of similar outliers here, and again, shown on the Bland-Altman plot here. So the bias still present, slightly reduced compared to the normal range, but again, apart from the outliers, very, very well within the actual acceptable confidence interval for the parameters. So overall, between the three levels for majority normal patients, we found that the correlation between both methodologies was near identical. So let's talk about the outliers now. So we managed to do some immunoplatelet counts on the platelets, the patients, but I don't actually have the details for those with me at the moment. What we did find is that the majority outliers showed a large variation between the two counting methodologies. One patient with a high CD41 count showed an increase in platelets on the optical count, and another patient showed an almost doubled increase on the optical count compared to the impedance count. That was for the outliers on the low levels. For the outliers on the high levels, again, one of the methodologies, we had an outlier where the optical count was a lot lower, but the CD41 immunocount was much higher. So that was very interesting. I think I will go on to discuss, yeah, that one was the cold hemagglutinin disease patient. So we're not sure whether that was because the sample was not warm when it was run, or whether it was a side effect of hemagglutinin, the disease itself, and the effects that that had. And then finally, we couldn't get, of the counts that we were running at the low end, we had 5 patients where we just couldn't get an optical flag at all. And that was because it flagged up with interesting fragments and abnormal red blood cells as it was counting them. And all of the patients that we had that on were hematology patients, who the majority were AML or CMML patients, and we had one very interesting new diagnosis of an MDS as well. So these are things that potentially, when you have the low platelet count, the optical flag could have given us a quicker or faster route to diagnosis through morphology, or at least given the morphologist a heads up on what they were likely to be seeing as it came off. So other interesting findings whilst we were doing this study, we had a few patients with microcytic red blood cells, and again it just shows with the impedance count being elevated and the optical count being reduced, the effect of those red blood cells, the microcytic red blood cells, had on the actual counts. We found no significant variance between, for the patient with CLL that we ran, or patients with triglycerides. There was no interference from lipid globules. The patients who were bone marrow transplant patients, again, the optical count was slightly improved, which may be implying that they had some larger thrombocytes present that just weren't able to be counted or weren't being counted correctly by the impedance count. Okay, and that brings me to the end of the actual discussion regarding the counts. So I'm happy to take any questions that you have.
Thank you, Dom. That was very good. Thank you very much. Yeah, I've got a couple of questions, as you quite imagine. Macrothrombocytes, where
Yep.
do you think the optical count will be able to give a better insight in macrothrombocytes?
We've got a patient at the moment who has a significant macrothrombocyte count that we've been running tests on for the last 6 months. She's an interesting macrothrombocythemia. We've been running optical counts, and they are mostly, depending on the patient's got a cytomegalovirus infection in the bone marrow, so that's why she's got the macrothrombocytes. Okay, when they treat the cytomegalovirus, she matches up with her impedance count and her optical count. When untreated, the optical count can be up to 50% higher than the impedance count. So yeah, the macrothrombocytes, it's a really good methodology for being able to track therapy and treatment of the patient, but you've got to know in advance what the treatment and therapy is, because on the days when she's been treated for her CMV and she's got that running through a system, the fact that the optical count is no different does worry us slightly.
Yeah, do you think there'll be some advantage in being able to shift the threshold manually on the optical platelet count?
There's
because
definitely
it will only go so far.
Yeah, there's definitely sometimes when I've seen the actual gating on the optical parameters and thought, well, if I could just nudge it up slightly, I know I guarantee catching the remainder of the count there. I don't know whether that's an algorithmic issue or whether there's options to change that, to move that gate or make that gate mobile, like some of the other gating for the differentials. But if you could manually change it, again, that would give us a temporary fix. But again, it would require somebody with knowledge and expertise in the area before you started doing that.
Yeah, it will be non-standard, therefore a bit frowned upon in this day and age, possibly.
Probably better for research purposes. Like I said, we haven't fully validated the test at the moment, so this patient is only for research purposes.
Yeah. The bias, you talk a lot about the bias. Do you think that could just be calibration?
It might very well be. Again, as we said, the test is not validated yet. We were doing this as a research project to see if there was correlation between the two.
Yeah.
I personally think that the bias is insignificant because it fits within the confidence limit of the actual correlation. So there is a bias, but it's not a consistent bias. It's not always a bias of the impedance being lower than the opticals or the opticals being lower than the impedance.
Yeah.
It varies between the two, which is why the Bland-Altman shows it better than the R-squared. Because sometimes you'll get a count where the impedance is high and the optical is low, and sometimes you'll get a count where the optical is high and the impedance is low. But it's not, taken as a count as a whole, it still falls within the confidence interval.
And on the samples with the low platelet count, there were 3 samples that were had a particular bias.
Yeah.
Can you remember what flags they had?
Let me have a quick look on the presentation for my notes on that page. Sorry.
I'm just interested because, as you know, that the optical platelet count was only really developed to get an more accurate platelet count when you've got microcytic red cells.
Yeah. I'm just having a quick look through my notes.
Yeah.
So, so one of them was the MDS patient, 543. Let's go back to it. Yeah. So this MDS patient here was run 2 times, and one of the times they ran, they were an outlier as well. So the optical flag came back much lower than the impedance count. So what we thought that was the interference of the schistocytes when we ran it, the same patient a couple of days later, because it gave us the flag then. It didn't give us the flag the first time round. I'm sorry, I don't have notes on the other 2 outliers for the low level.
It's okay. So the optical platelet count was probably doing its job then.
It was, yeah, definitely.
It was more accurate, an accurate count than the impedance, because that was including platelet frags.
Yes. So this is where it is actually interesting to see it. So yeah. Any other questions?
None as yet. Everybody's been very quiet.
I like that.
I wanted them to give you so you could have a good grilling. Unfortunately not. But no, that's great. Thank you very much, Dom. And I think this is going to be, I'd like to think, a project that will be ongoing.
Well, we've got plans to set it up now. So we've looked at normal patients. Now we need to start looking at abnormal patients. Yeah. So one of the populations that we really want to look at in the future, we're going to look at some of the, following on from David's presentation just now, we're going to look at some of the thalassemics and the sickle carriers, and see if there's any variation there caused by the macrothrombocytes they have in their circulation. Again, the study that we're doing at the moment with the patient with cytomegalovirus, she's got an interesting case of TTP caused by the cytomegalovirus. So there may be room to work with the coagulation consultants there on looking at some of the TTP patients who do show megathrombocytes or macrothrombocytes within their morphology, and studying them in terms of tracking their recovery or tracking their treatment. So there's 2 that we're interested in.
As ever, Dom, we're here to support.
Yeah.
Whatever. I'm
I
sure
will steal your knowledge at some point if I need it. I promise you that much.
Well, that won't take long, so you're okay. But no, that's great. Thank you very much, Dom.
It's a pleasure.